All right, welcome to the respiratory section. So this is going to be a good portion of Unit 3 in the Unit 3 exam. This particular slide presentation is foundational. There may be questions that require knowledge of this content, but not specifically from this slide. But in order to understand the pathophysiology behind COPD, pulmonary fibrosis, any other types of respiratory issues such as ARDS, pneumonia, it is fundamental that you understand the physiology of how we breathe and the structure of the lungs. These are the course objectives. I'm not going to read these to you. You can read those on your own. Now, we'll start with function. So there are three primary functions related to the pulmonary system, and they are distinct, and they have specific purposes and functions in the body. First is ventilation. Ventilation, when we say ventilation, we're not specifically talking about a ventilator. A ventilator does ventilations, but you are ventilating right now as you're sitting watching this video. Ventilation is simply moving air and or oxygen in and out of the body. Diffusion is the process of moving oxygen and CO2 in and out of the body, specifically across a membrane. We are diffusing O2 across the membrane, and we're diffusing CO2 across the membrane. So both of those are diffusive actions. Also, we're going to be discussing perfusion. Perfusion is the process by which oxygen is moved into the tissue. So that's the other function of the pulmonary system. So within diffusion, you have both the management of CO2 and the management of O2. O2 having the function of oxygenation, and CO2 being the measurement of ventilation. We'll talk about that more as we move through the conditions, but you also know this already from the blood gas material we've covered so far. The basic anatomical structures should be fundamental to your knowledge. The one thing I want to call out here, so I'm drawing attention to the goblet cells and the way the airways break down ultimately to the alveoli. Before we get there, I want to emphasize the epiglottis. We think of the epiglottis as a protective structure. It is that. However, it also provides what we call positive end expiratory pressure. It generates that for you at the end of exhalation, which allows your lungs to stay partially inflated. This makes it easier for you to take your next breath. So the other thing I want you to be familiar with from this slide is the alveolar space. The alveolar space is where the issues, the function of oxygen and diffusion take place, which is fundamental in order for perfusion to take place. So alveoli are central to that. In fact, to emphasize this, the alveoli comprise the greatest surface area of your lung tissue. About 75 square meters of surface area is what you have within a normal size human in the chest cavity. That is diffusive or oxygen exchanging, CO2 exchanging space. That's about the size of a football field. Now, the other thing that is critical to these anatomic structures is going to be crucial as we go forward is this thin space in between these two structures and the two membranes on either side. This particularly on the lung side. So you see a red blood cell here, and then you see an alveolus over here. So this structure on the alveolar side is the alveolar capillary membrane. And I'd like for you to notice that the alveolar capillary membrane is smaller in thickness than is a single red blood cell. So what that tells you is this barrier between the inside of the alveolar space and the bloodstream is smaller than that of a red blood cell. It's very thin. So this basic principle will illustrate the complications that arise from things like pneumonia, pulmonary edema, and other problems that affect this alveolar tissue. Now, this particular slide is important to understand the portions of the lung that are responsible for conducting air into and out of the lungs, and those that are essential for exchange or respiratory zones. In fact, where oxygen is able to diffuse. So you notice from the top of the screen here going down, the trachea bifurcates into the bronchi, the right and left main stem bronchi, and then it further differentiates into bronchioles, then into terminal bronchioles. Then you move into respiratory bronchioles. These areas are primarily for the movement of air. When we move below the bronchioles, then we move into alveolar ducts and alveolar sacs where oxygen and CO2 are actually exchanged. What I have for you here on the right, this histology slide, is a representation of a cross-section of alveolar sacs, which is the large white space. You notice these large white spaces, and then you'll see these red dotted outlines that shape and create the white space. Those red dots that look like they're capsules, they are in fact red blood cells. So they are stained with a dye that helps them to illuminate on this slide. The alveolar space is essentially filled with air. So this slide shows you, one, the surface area of alveolar space relative to the vascular space, but also shows you how thin this alveolar capillary membrane from the previous slide is. So this area where these red capsules are red blood cells, and just outside of that white space is the alveolus. So you could see how dependent we are on that thin membrane in order to make that exchange happen. This image is an electron micrograph image that shows you a red blood cell, and the white space around this red blood cell is alveolar spaces adjacent to either side. So this is, if we took this portion where the arrow is pointing and magnified it under an electron microscope, we would see these structures. This is another image of those structures. The image on the left here, well, the one on the far left is the one we've seen to this point. The image here in the center shows you right in the center of this slide, you see what is a bronchial or perhaps a terminal bronchial, more likely a terminal bronchial. Adjacent to that, you see these small black and white sacs. Those are alveolar spaces. You can see all of the alveolar spaces here adjacent to this terminal bronchial. Now, this slide on the right, on the far right, is again another electron micrograph image. And what you see here, you notice these white lines. Those white lines demarcate the outline of an alveolus. In this case, we're looking at the surface of an alveolus, and all of these dark spots reflect the ends of capillaries as they surround this alveolus. So there is not just one capillary per alveolus. There are, as you can see in this slide, hundreds or thousands of capillaries that surround this alveolus in order to help oxygen exchange happen. This image is meant to reflect to you, it's not something to memorize, but it shows you the cross-sectional area, as you can see here on the left. So 100, 200, 300, 400, 500 shows you the surface area of the conducting zones versus the respiratory zones or alveolar zones. So you notice as you go to the right, as you move along the conducting zones, and then you move toward the terminal bronchioles, there are far more terminal bronchioles than there are bronchi or trachea. Once you pass the terminal bronchioles, you'll notice that the surface area in centimeters squared skyrockets up to 500 or more centimeters squared of surface area. This number up here reflects the alveolar spaces. This is where we're actually exchanging oxygen. All right. So in your future as a nurse, there are going to be some images that you're going to see and that I'm going to show you in class. And then as you're in clinicals, we'll be calling these out to you to take a look at chest x-rays. Not that we expect you to interpret them, and you will not be interpreting them in class or on a test, but the one way to understand the lung is to look at pictures of the lungs, and radiographs and CTs, MRIs are the best way to reflect those conditions. So this image you have before you is a relatively normal chest x-ray. So when we create a chest x-ray, we're using essentially light to penetrate a chest or whatever cavity, whether it's an x-ray of the head or the leg or whatever, we're using light to penetrate that. The more light can penetrate an area, the darker that will be on a chest x-ray. Or a better way to say that is the better an x-rays can penetrate a body cavity will show up darker on a chest x-ray. So here's what I mean by that. You'll immediately notice the light white spider-like lines across this chest, and as you've probably guessed, those are ribs. So along the chest wall here, you have multiple ribs on each side. In the center, you have a very opaque area. This is shaped somewhat like a triangle, and you can also see a very opaque structure down here at the bottom. Now, you may have intuitively figured this out. You may have seen x-rays before, or this could be your very first one. If you'll notice, between the ribs, there is a darker area of space. That is where the x-rays are penetrating an air-filled cavity. Those are the lung field, both on the right and the left. So that tells us that those are very easily penetrated by x-rays. These wider areas in the center are either bony structures or a combination of bone structures and structures that are muscular and or filled with blood that create this very opaque and dense structure that the x-rays cannot penetrate. As you might suspect, here in the center portion, this is the heart. This dark, it looks like a tube. It appears to be laying on top of the heart. It's actually running behind it is the descending aorta. It is filled with blood, and that's why it is so opaque. You also can see, starting up here where the collarbones come in, you can see the sternum. So we have bone and vasculature, and then here we have bone, vasculature, and the heart muscle, which has both muscle tissue that's filled with blood and blood within the atria and ventricles themselves. So very opaque region here. This bottom portion down here that's shaped kind of like a large bean is the diaphragm. So again, the diaphragm, very large muscle, very dense muscle, and a very vascular muscle. So between the density of the muscle and the vascularity of the muscle, all of that blood flow within the diaphragm creates a opaque image. And then you notice a slightly lighter image here, this oblong looking structure. That is an air bubble in the stomach, which is sitting on the diaphragm. Next, we have a CT image. A CT image. So this is a CT scan. And in the CT scan, I just want to point out some basic structures so you're familiar with what you're looking at. These lines that go up at an angle on each side, those are collarbones or perhaps the scapula. I'm not exactly sure which slice this is. You can identify the vertebrae right here. So this is the bottom portion is the person's back, and this portion is the vertebrae. You see these oblong areas on each side. Those are ribs as they come around the chest, and ultimately you see the sternum right here on the top. So this is the person's back, and this is the person's front. You'll notice in this slice, you see a very large right lung and a much smaller left lung. That's because we have a heart here in the center. These opaque areas are side views of different vascular structures. This very dark one in the center is looking directly down into the aorta. And then here this area would be where the right atria and subsequently right ventricle, and then the left ventricle over here on this side. This area of lung field, you notice it's very dark. Again, the CT emissions can pass easily through the air-filled sacs. What these little white spots are areas where the blood flow is moving around the lungs. This patient has been given contrast, and that contrast is easily visible where the contrast moves through the vasculature and easily visible on the CT scan. This is a normal CT of the lungs. Again, the spinal column down here at the back, the sternum, this portion here in the front, and this is the heart, and this very dark area here in the center is the aorta. Now, let's talk for a moment about ventilation. We've already talked about ventilation when we discussed blood gases. The effectiveness of someone's ventilation is measured by CO2. CO2 in a blood gas tells us how well that patient's ventilating. Or it may tell us if there's pathology in the lungs that impedes a person's ventilation. So there are a few measures that we use also to assess the amount of ventilation. One of those is tidal volume. Tidal volume is the amount of air you take in and out with each breath. Most of us just sitting and taking notes or lecturing are breathing somewhere between 300 to 600 milliliters of tidal volume. That just varies slightly from individual to individual. That doesn't mean that's one's lung capacity. We have far more lung capacity than that. A more precise measure, because again, I'm going to say it again, tidal volume is the in and out of each breath. Minute volume tells you how well you're ventilating over time. So, for example, if someone is breathing 500 milliliters with each breath, that's a fine breath. But if their next 6 breaths are 100, that's not good. In this example, you notice below tidal volume where there's minute volume, if a person who's breathing 500 mils a minute breathes 10 times a minute, then their tidal volume is 5,000, which falls in the approximate normal range for a tidal volume. If they were to breathe 12 times a minute, then it would be 6,000 mils. If they were to breathe 20 times a minute, that volume is going to be 10,000 mils. So you can see how a breath over time can drastically change one's minute volume. And this is the key measurement for how much volume a person's actually moving. The CO2 tells us how effectively that volume is moving and exchanging carbon dioxide. NIF, it stands for negative inspiratory force. This is a force that you have already. You don't appreciate it until you're eating or drinking and something goes down the wrong pipe, and you can cough that up and force it out. Negative inspiratory force is that capacity to force air out in a negative direction. And that's what we are referring to when we're talking about coughing, that forced air out. You will occasionally see what are called PFTs, or pulmonary function tests. These tests are more precise measurements of lung capacities, and these four are the common capacities that are measured. There may be a few others depending on what the physician is suspicioning may be wrong. They may do a total lung capacity with DLCO or whatever. There are a few other tests. Total lung capacity, this is your capacity to inhale as much as absolutely possible. So for this varies based on age. For me, for example, my total lung capacity is around 4,000 milliliters. I know this, I have an incentive spirometer at home from doing things just like this. Functional residual capacity, this is the difference between your tidal volume and what you can breathe deeply to capture. Residual volume is any volume that remains in your lungs after you've exhaled. And then forced vital capacity is how much you can force out of your lungs. It's pretty much what it sounds like. You'll see PFTs done on occasion when we need to be more diagnostic about what's going on with this patient's lungs. Ventilation is directly connected to respiratory rate. As we saw from minute ventilation, it's connected to respiratory rate and tidal volume. And tidal volume is commonly in your lives going to be measured by incentive spirometer, or by an incentive spirometer or incentive spirometry. The other measurement, as I just mentioned, we're going to be looking at is minute volume. Again, CO2 tells us the quality of that exchange, how well that ventilation is functioning to exchange CO2. What I really am using this slide to do is call your attention to regional differences in ventilation. So this slide to the right, what we do is this picture to the right, we have a patient inhale a xenon gas within oxygen. It doesn't affect oxygenation. It is just radioactive enough that we could count where it moves into the chest wall. So I don't expect you to know that for the test. What I really want you to notice is this section to the right, and we'll talk about this in the classroom, that we commonly expect that we breathe more in the upper regions of the lungs because air rises. That may be where air is inclined to go. However, our best ventilatory unit, if you notice here, is the lower lobes of the lungs. The middle lobe is second, and then the upper lobe is last. This has to do with the surface tension that's on the structures based on gravity, and this we'll discuss in class. Now, as you know, you've been listening to lung sounds, you know that they sound different across the thoracic cavity. That has to do with whether or not the air as it moves is encountering structures that create turbulence. So here we have three different types of airflow: laminar, transitional, and turbulent. Don't worry about these p-values underneath. Don't worry about those. What I want you to notice here is in the tracheal area. So when we're assessing our patients, one way to assess the patency of the airway is to listen over the trachea. So we listen over the trachea, we hear a very loud, but what is called a laminar flow sound. That's that sound of air moving through the trachea, unless there's an obstruction, and then we may hear a slightly different sound. When we move down lower over the chest, where the two two bronchioles bifurcate to the right and left. That's what the transitional airflow here is. You notice this peak right here in the middle of the Y depicts the carina. As air from the laminar flow moves and hits the carina, there creates a small amount of turbulence. So bronchial breath sounds sound very different than the laminar flow over the trachea. Also, the turbulent flow in the lower airways, when you move into the alveoli, that's more of a passive diffusive exchange because the airflow slows down as it moves to the alveoli. You have a quieter, softer sound, and commonly you don't hear very much if there's not fluid in that region to create a raucous or rumbling type sound or crackling type sound. That's what we mean by turbulent flow, those sounds you hear over the lower lobes of the lungs when auscultating a patient. Let's speak a minute about diffusion. So there are some basic principles about diffusion. And specifically here, we're talking about diffusion of gases. More surface area means there's more gas diffusion through tissue. So for example, this would be intuitive if I say it this way. If someone only has one lung, they have less diffusive area. So there's going to be less diffusion. It's intuitive that they're going to have to work harder in order to make effective gas exchange. So conversely, the more surface area we have, the more alveoli we have working in our favor, the more gas diffusion, both exchange of oxygen and CO2, is going to take place. We've got more tissue to do that. This is why the alveolar surface area is so high. Also, thicker tissue means less gas diffusion through the tissue. So another way to say that is, if the alveolar capillary membrane becomes obstructed with fluid or infection, functionally, that tissue becomes thicker. If the tissue itself is injured and becomes inflamed or edematous, then the alveolar capillary membrane is thicker. So the gas has a harder time moving through the tissues. Then the last thing is, the more soluble the gas is. In other words, if something about that gas, that a property, allows it to move more easily through a membrane, you're going to get more diffusion. For the sake of our studies, it's important to know that CO2 is 20 times more soluble than O2. This is what keeps us from developing hypercapnia. This image is one that's in your book. It's in a variety of reference material, but I just want to point some things out. When we're breathing, any breath we take has different proportions, or what we call partial pressures, as we've discussed when we covered blood gases, partial pressures of different gases. So in the center here, in this yellow portion, which represents a terminal bronchiole and then an alveolus, notice that the PO2 in the terminal bronchiole is, the partial pressure of oxygen is about 158 millimeters of mercury. This is a result of air around us that's approximately 21% oxygen. Notice the difference. 21% oxygen generates a partial pressure of 158. We don't have a partial pressure around us because we don't have a fixed container. When you have a fixed container, then that gas is exerting a partial pressure. The partial pressure of CO2 is 0.3, and then you have nitrogen and water. So there's moisture in the air. This partial pressure of 158 in the terminal bronchiole generates a partial pressure of oxygen in the alveolus of approximately 100 millimeters of mercury and a PCO2 of approximately 40 millimeters of mercury. So this is where that diffusion capacity of carbon dioxide compared to oxygen is so critical, as carbon dioxide moves into the alveolus and oxygen moves out. Notice over to the left here, the partial pressure of O2 in the vein is 40. So if your partial pressure in the alveolus is 100 here and 40 here, oxygen is going to move this way into the alveoli, into the bloodstream, into the pulmonary capillary. And notice the PA pressure over here, 97 millimeters mercury. Conversely, CO2 here, 46 millimeters of mercury, but recall, in the terminal bronchial, it's very low, 0.3 millimeters of mercury, and CO2 is very easily diffused across this membrane. This creates an alveolar partial pressure of 40 millimeters of mercury. So this CO2 is going to move downstream, which is exactly what we want in order to maintain adequate ventilation. So the atmospheric pressure around us is approximately 760 millimeters of mercury. After humidification, this drops to about 713 millimeters of mercury. So what does that mean? Well, one thing I failed to mention here is that when the diaphragm contracts in our abdomen or lower thoracic cavity, it creates a lower negative pressure than atmospheric pressure to cause air to move into our conducting airways and diffuse into the exchanging airways and create this gas exchange. So now we've talked about how we ventilate, we've talked about how we oxygenate and the pressures behind that and how diffusion happens. So now what? Here the key is perfusion. This is the ultimate measure of the efficacy of our lungs. Are we getting rid of enough CO2? Are we getting in enough oxygen? So are we ventilating? Are we oxygenating? And then we have to have, like I mentioned in some of the very first lectures, an efficient cardiac output so that tissues can be perfused. How do we assess perfusion? Capillary refill, among other things, which we'll discuss in class. So we have to have those three legs of the stool: ventilation, cardiac output, and oxygenation, in order to create perfusion, which is the ultimate assessment of how well we are breathing, how well our lungs are functioning. So there are two key steps that are critical in order for perfusion to take place. One is we've got to get oxygen onto hemoglobin. That's the first step. So this has to do with, one, how much hemoglobin we have. Do we have enough? And two, are we getting oxygen into the alveolus and across that membrane? Oxygenation, diffusion, in order to get perfusion. Then we have to get that oxygen out to the tissues. And this is where cardiac output and vascular permeability are so critical, because we have to be able to we can have the hemoglobin saturated with oxygen, but if it can't move out into the tissues, then the tissues don't get oxygenated. Just a little side note here: each molecule of hemoglobin binds 1.3 mils of oxygen. So we'll pause right here. In the next video, we'll pick up with the oxyhemoglobin dissociation curve.